Ashraf boleh confirm dengan saya slide saya dah maximize presented?
Belum.
Belum ah?
Belum dalam
Right.
presentation.
Tak silap saya lagi ada 3 orang maybe.
Ya, betul doktor.
Kita dah cukup ke?
I think like one more.
One more, okay. Ashraf boleh nampak saya punya slide? In full view.
Boleh, tapi I can see no, not full view. Sebab nampak yang
Oh, dia
belah
bukan yang
kiri
full
tu.
view ah. Alright, okay.
Dia bukan full view.
Okay, sekarang dah full view ke?
Still the same.
Still the same. Thank you.
Yep.
Okay, kita dah cukup. Admit, alright, okay. Okay, bismillahirrahmanirrahim. Assalamualaikum everyone. Alright, okay, so today is your tutorial on GERD. First thing first, please log in into your UFuture and confirm your attendance. Right? Right, okay, so let's have a recap of our previous lesson on GERD. I think I missed one group of drugs that can be treated using, can be treated for GERD, that is the Presence, okay? So this is FDA approved, and it is mainly for erosive esophagitis, but it is actually more indication that can be or under investigated, okay, that can be used. This is oral medication, and of course this is PCAB, that is potassium competitive acid blocker. they say that after a few clinical trials and systematic review, there is no what we call it non-inferiority towards PPI, meaning to say that they are better than PPI but not less. And it is also believed that they have 350 times more potent than all the PPIs. And because of these new drugs involve GI tract, so ADR will be related to all these gastritis, diarrhea, abdominal distension, abdominal pain, and nausea. Okay, so other than vonoprazan, we also have fezukever, reva, and tegoprazans. This is the 2022 paper by Wong. And in fact, I already uploaded a copy of this full paper where you can have a look so that you can learn more about the presence. Okay, and the most important part is that here we have a different indication that being approved to be used for Prazan. Basically will be based on the region. For example, in the case of the United States, they will be like already approved for H. pylori indication. And for other countries, they already expand or augment all the indication to all these, complicated GERD, as well as can be used for pregnancy and can be used in pregnant women or lactated mother. All right. So that will be the indication that they have. And let's look at the comparison between PCAP and PPI. The advantage of PCAP is actually they are better in terms of tolerability, okay, as compared to PPI. The first thing is that it is not pro-drugs as compared to PPI. PPI, you need 2C19 in order to get activated version of PPI, where it must be converted. But this one is not necessarily have that conversion. And the second one is that it has faster acid suppression, as well as require lesser frequency, because of 1 day after dosing, you can get the beneficial effect. While as compared to PPI, it takes longer. And of course, because of the half-life is longer than PPI, then the dosing will be much better. So most of PPI are being formulated as what we call it sustained release or time release. So that really compensate back all the disadvantage of this half-life. Again, as I mentioned earlier, doesn't need C2C19 for metabolism in order to function well. Therefore, PCAP is more being used in the Asians, all right? Because Asian basically will have that polymorphism, pharmacogenomics, pharmacogenetics methods. So whenever we have Asian, it will be much better to use PCAP rather than PPI, because we don't know whether they have sort of variation in terms of C2C19 in terms of metabolism. So probably Asian could have less effective whenever taking PPI because of less activated prazoles. However, whenever we give PCAP to Asians patient, they definitely will benefit. Okay, most of them won't have all these pharmacogenomic polymorphism. Again, this doesn't applicable, okay, for PCAP whenever you want to take the medication, particularly meal times. But for PPI, definitely you have to take prior to meals, which a little bit, bothersome for some patients because they have to remember when to take the medication. Again, another papers in 2022 by Phil and friends, okay? So vonoprazan is actually very safe, okay, as compared to others existing medication to treat fatty ulcer, esophagitis, as well as NSAID-induced GERD. Not to mention that it is superior to PPI in first-line H. pylori indication and erosive esophagitis. Okay, so you can have a look at this Simbadi Brata systematic review and meta-analysis for more information about the comparison. All right, okay, so let's scan with your handphone, okay, for this QR code, because we are going to have a very interactive session, okay. All right, okay, so these are the learning objectives. So let's scan, okay. Can you just raise your hand when, or maybe you just give me thumb ups, okay? Thumbs up if you already see the questions on Mentimeter.
Mr. Fauzi,
Yep.
saya punya slide tu dia tak nampak.
Slide tak nampak?
Ha,
Alright.
slide tu tak nampak.
Alright, okay.
Saya cuba.
Something wrong with this Jimmy. Let me check. Sorry for the technical difficulties. Right? But can you see the on?
The question?
I see the question, but can you see the QR code to enter?
Yes.
Mentimeter?
Yeah, sama. I cannot
on,
see.
right.
Yeah.
Can you see now?
Yes, better.
All right, okay. So can you see how about the rest of, I mean, the presented slide prior to this? All right, okay. So never mind. So the learning objective will be here. All right, okay. So let's recap our case. Whenever you read all the case, just highlight all the important notes here. Like for example, heartburn at night, geriatric women, heartburn 4 to 5 times, regurgitation, and then acidic taste in mouth, and then birth at night, and then during sleeping, worsen, cough at night, difficulty swallowing, no, okay, no dysphagia, no complication or alarm symptoms, and then lansoprazole 24 hours, okay, used for past 3 weeks, okay, and then frequent PRN, got asthma, and then history of cancer, and then wine, got financial support, and then amlodipine, aspirin, okay, and then cough at night, heartburn after meal, and then worse at night. Then just highlight whatever related to GERD, okay, obese, bowel sound positive, okay, and then labs abnormal will be, you know, you see fasting glucose, you divide by 18, okay, 220 divide by 18, you get like around 12, which is uncontrolled for diabetes, and then AC glycosylated hemoglobin is 9, which is very high, all right, so you have to interpret that as well. Okay, so these are the questions. All right, okay, so let's get straight away to the question. Very good. You have all the answers, okay? Basically will be regurgitation, coughing, okay, asthma light, and then you also have heartburn is also known as pyrosis, right? Pyrosis, and then acidic taste. Very good, okay. But we don't have endoscopy, okay, to detect whether the patient is having erosive esophagitis. Let's assume that the patient has erosive esophagitis. Then the treatment will be different. Very good. All right. Okay. Nice. Okay. Now, the second question is, okay, you can have a look at this, you know, clinical presentation. Basically will be, you know, all this stuff, and then followed by dysphagia. Right. Okay. Can you see this, the second question? What objective information indicate the presence of GERD? Is there any problem? All right, very good. Obese. That is through BMI. BMI is about, yes, 100 kilogram over 170 centimeter maybe. So it is obese +1, all right? A1C. A1C seems not quite right actually. Okay.
Hang on lah.
Regurgitation is more on the frequency. Okay, you can answer by expressing the number or the frequency of regurgitation. Okay, that could be the objective. Right? Good. All right. Okay. So never mind. So definitely we need to do endoscopy. High risk patient will be more prone to have all these what we call it objective information. All right. Right. Okay. So next, additional information is needed to fully assess endoscopy. Very good. Okay. In fact, we do have a lot more. Okay, but that will be like manometry. Okay, which is very complicated. But definitely we need to do endoscopy. Remember, whenever we want to specify esophagitis or at least GERD, they will be like using endoscopy visual examination. Okay, it's either you have GERD with erosive esophagitis, erosion, or without erosion. Erosion meaning to say that it has some kind of like inflammation, okay, damage or diminishing of mucosal lining of that esophagus. So in this case, whenever we check through scopy, if it is presented, then definitely it will be with erosion or erosive esophagitis. The second one is without, okay, but again, those without, without or with, okay, sometimes, more than 50% can have what we call erosive esophagitis, okay, or can have what we call GERD without erosion, right? Okay, so the next question is assess severity of GERD symptoms in JS.
Sorry, Dr. But the slide is not.
The slide is not
moving.
presented.
Slide not changing.
Yeah, it's still on the.
All right.
Slides
Okay.
not moving.
Never mind. Just ignore the slide. Just look at your mobile phone, maybe. Okay, everyone, have you? Right. Can you see the slide now in full view? Still no?
No.
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 Still no.
This is really bad. Okay, so assess the severity: cough, underlying asthma, uncomplicated, All right, moderate to severe. Okay, so moderate to severe, it depends on, basically depends on the results from endoscope. Since we don't have data on endoscope, so we cannot actually thoroughly assess the patient. But looking at the symptoms and complaint from the patient as well as the objective data that we have, I think this can be said that especially the nocturnal reflux. Okay, that is actually one of the indicator saying that the patient is actually having moderate to severe. Because frequent nocturnal reflux is actually indicate increasing severity of reflux or esophagitis. So in this case, may cause more mucosal injury, and definitely will be will reduce what we call it quality of life, because it will disturb the sleeping pattern of the patient. So 65% might have at least once, okay, for nocturnal heartburn, both in daytime as well as at night. So that could be one of the things that we can say the patient is having moderate to severe. Okay, so that nocturnal symptoms will be one of the important clinical presentation. Okay, so create a list of these patient drug therapy problems and prioritize them. Just give me a simple DRP maybe.
And can I say metformin also can
Can. You
can
did,
can
yeah, you have one of the DRP, okay, for this patient, which is ineffective oral hypoglycemic agent treat diabetes mellitus. Very good. What else?
Starting treatment.
stating for
Yes,
LDL.
High
exactly.
CT.
Because patient is actually woman, postmenopausal, geriatrics, patient having diabetes as well as hypertension.
High risk.
Okay.
And obesity.
Yeah, high risk obesity and on low dose aspirin. So you're gonna need sort of cholesterol, okay, cholesterol medication. But again, it must be not interacting with PPI. Very good. Inappropriate drug use, aspirin indicated for this patient. Why?
Start
Anyone?
PPI. Start PPI once daily, and then start aspirin.
Start aspirin. You mean because of PPI, is it?
Start PPI for GERD, and at the same time, we need to start the aspirin for heart attack prevention, and at the same time, both of them can work together.
All right, cool. Yep. That can be one of the DRP. Inadequate dose of PPI, yes. Patient is actually,
Yeah.
well, it is not inadequate, but it's more like, you know, using more than 2 weeks, okay? She used for 3 weeks, remember? So PPI cannot use more than that, okay? Basically, you need to do some sort of re-evaluation, okay? Whenever PPI is no longer taken as directed, okay? Based on the prescribing recommendation. So that could be one of the reason, or DRP. Ineffective oral hypoglycemic, definitely. Lipid profile high, initiate statin, yes, what we have mentioned previously. Ineffective, yes. Increase the frequency, yes, but we have to re-evaluate the patient, how she take the medication, PPI.
So can we say metformin also has GI side effects, which is
Yes,
dyspepsia and belching as well. So might be might to monitor patients. How does she take the medication after meal or yes.
well, actually, first, regarding of the diabetes, patient on metformin and patient on metformin, but not at maximum dose. Remember, A1C and glucose is still high, so we can maximize the dose of metformin. Now metformin is 500 BD. If I'm not mistaken? So you can always increase 1 gram to TDS. But we also afraid that the patient is diabetes mellitus patient. So that could lead to what we call it, you know, the problem with diabetes, something to do with GI tract. Anyone?
Okay.
Anyone? Okay, we have a condition called diabetic gastropathy. Okay, that is actually the autonomic dysfunction, where you have delayed gastric emptying. So that also contribute to GERD. Okay, but again, that is not DRP because it's related to the disease. Okay, so good. You have identified. How about BP? Would you like to comment on BP? Amlodipine?
Not controlled
That had
with
yeah.
the
Yeah, so that is actually one of the drugs that can reduce LES pressure. Okay, not to mention that aspirin also irritate the mucosa. Okay, so these two medication can contribute to GERD. So that would be DRP in this patient. All right. Okay. So next, what patient or lifestyle factors could be contributing to GERD in JS?
alcohol,
Definitely wine, alcohol,
obesity,
obesity, definitely because it reduce or increase LES.
uh,
Increase intra-abdominal pressure,
so less LES, reduced LES.
very good. Okay, so obesity, alcohol consumption, definitely. And of course, because of the diabetes itself, like I mentioned previously, that would be diabetic gastropathy, all right? Delay gastric emptying. So that could be the factors. Okay, next. What are other potential complications of long-standing untreated GERD? Very good. Barrett esophagus, cancer, Nice. Erosive esophagitis, definitely. All right. Stricture, yes. Okay, stricture is more like, scarring. Okay, so it can cause dysphagia, okay, odinophagia, while Barrett is actually more on, shift, okay, shift or that the initial part of the stomach will be, trapped into the sphincter, right? So that could be the complication. Nice, very good. Okay, next. What are the goals of pharmacotherapy for this patient? Of course, we want to rapid release, okay, all this clinical presentation, reduce frequency, duration, severity of reflux, and then heal esophagitis, prevent recurrent, okay, avoid complications, improve quality of life, provide cost-effective treatment, and then we also want to use proper drug therapy, right? So that would be the goal of pharmacotherapy in this patient. What lifestyle modification, non-pharmacological therapies that may improve patient symptoms? Reduce alcohol intake, very good. Alcohol intake and dietary fat intake, okay, food as well, right? Exercise to reduce, okay, very good, okay. Exercise, avoid sedentary, okay, this is more like alcohol and weight management. So how about the rest? Avoid triggering food, yes, especially meal size as well, okay, meal size, ni lah, hidangan, portion size. And of course, avoid spicy, avoid eating prior to sleeping, okay, carbonated drinks, tight fitting garments, right, smoking cessation if smoke. Remain upright 2 to 3 hours after eating. Okay, that could be one of the lifestyle modification. Okay, so next question is feasible pharmacotherapeutics alternative available. Anti-reflux surgery, yes, okay, that is not drugs, okay. Okay, pro-motility agents, sucralfate is among the drugs that can be used. Remember your PPI, what else? Your antacid, you can use, but they are not that effective, all right? Alginic acid, okay, good. Okay, next is create patient-centered care plan, okay, to optimize medication therapy. So what would be the, the the solution for each DRP. Okay, let's say we have the first DRP is inadequate treatment for GERD using PPI or lansoprazole. So what will be your solution for this? Let's say patient has erosive esophagitis after undergo GI endoscopy. Double the dose. Okay, yeah, you can maximize the dose of PPI, right? Also, you can opt for antacid. Okay, you can add antacid, okay, on top of PPI. But PRN, okay, so that could be one of the, you know, example. But again, don't yep, definitely the latest medication, vonoprazan. Okay, you can opt for that. That is better in terms of efficacy as well as tolerability. Very good. Okay. Okay, the second DRP, aspirin use. Remember, patient needs cardiovascular protection, so you are not allowed to use aspirin because it causes irritation to your GI mucosa. So what would be your solution for this? All right, okay, so can you use clopidogrel? Change to cardioprin is the best solution, all right? Yes, actually you can use together with PPI, okay? That would be much better than MMT, okay, in this case. Okay, how about the third DRP, that is uncontrolled hypertension? Remember, patient on amlodipine, but BP is still slightly high. COX-2 basically will be for pain, okay? Aspirin here is used not for pain. So change to COX-2 is not our option. Increase the dose of amlodipine. I think you should, you know, rather than using dihydropyridine CCB, maybe we can change to ACE and ARB. Very good. Okay. And then you also have to look for the patient lifestyle. Okay. Diet, for example, DASH diet. All right. Salt intake, and then remember, patient on diabetes. Okay. Patient can get more benefits. Okay, by using ACE and ARB as compared to CCB. Okay, the fourth DRP is actually uncontrolled diabetes mellitus. So what are you going to use for this? The patient on metformin? It's either you put new drugs, okay, or maximize metformin first, and then you change to newer drugs. Like, for example, you have GLP-1, okay, sodium SG, SGT, okay, inhibitors, all those, you know, insulin or oral drugs, okay? So you can change to another pharmacological class. So a lot of you are saying that you need to start some kind like anti-lipidemia therapy here. So what would be your suggestion? Just open up your mind and let me know. What would be your suggestion for statin therapy for this patient?
Atorvastatin 40.
Right. Okay. So you can opt for atorvastatin. Would you like to have high intensity? 40 milligram? Well, maybe you can start with low intensity first, okay? Like 10 milligram first, okay? So you can opt atorvastatin or rosuvastatin, maybe 10 milligram or mid range, okay, like that. And monitor all the lab values, okay? Lipid panel. Okay, very good. All right, okay, so the next question is, what information should be provided to patient to enhance compliance, ensure successful therapy, and minimize adverse effect? Okay, so your answer is how to take meds. Yep, that could be one of the information that you would like to share with your patient. Okay, especially when patient is about to take PPI. Okay, remember PPI can always take by mouth. Okay, before first meal of the day. Okay, so that will be the advice that very important. Okay, good. Counseling, drugs. All right, single day daily dose, monitor pain, ADR. Okay, yep. So basically, you will do all those monitoring. Okay, like what you have suggested here. Other than that, will be implementing lifestyle modification. Okay, healthy. Okay, dietary modification. And then do weight loss, as well as to record the symptom in diary. Okay, that could be things that your patient should do, okay, in order to monitor for the efficacy. Right. Okay, so next question is, describe how care should be coordinated with other healthcare providers. Who are you going to work with in order to treat this patient?
Dietitian.
Exactly. Whenever it involves all the triggering food. Okay, GI surgeon, gastroenterologist. Very good. Would you like to have physio or occupational therapist? Because some kind like weight loss involved.
Yes, we need.
Exactly. Okay. Nurse, not to mention nurse. Okay. Whenever you have diabetes, like diabetic educator, mostly nurses have this kind of qualification. They could be a very good healthcare providers. Right. Okay. Good. Next is what clinical and lab parameters should be evaluated. To be evaluated, right? Okay, when we talk about monitoring, remember there are three big things: efficacy, toxicity, and interaction. So efficacy, what do you monitor?
Monitor symptoms.
Exactly, clinical presentation, and then also monitor adherence. Okay, monitor symptom, bone porosity. Well, patient is women and diuretic. Yes, possibility. Okay, especially with the use of PPI. Okay, monitor symptoms. Adherence, don't forget, monitor adherence by using your my map, okay, or Morisky. And then monitor alarm symptom. Yes, definitely look for the complications. But also you have to monitor the use of antacid and relief of symptoms. Okay, because sometimes they take too many or too frequent antacid, which is not good. Okay, it will start to make all these blood electrolytes to change a bit. Okay, so that is efficacy. How about ADR or toxicity? Yep.
Take PPI not more than once a day.
Pardon?
PPI need to make sure need to be taken only once a day, not twice a day.
Yep. That is more towards adherence drug. But toxicity, look for all the ADR, okay, for each prescribed medication. For example, in the case of PPI, bone porosity test would be one of the useful tool, okay, to monitor osteoporosis. Okay, how about drug-drug interaction? Okay, you check whether they are interacting, then you use drug interaction probability scale, okay, DIPS. That could be also our main rule. Right, magnesium level, definitely. And then, of course, for the comorbids, okay, like, for example, high cholesterol, hyperlipidemia, as well as diabetes, okay, or hypoglycemia. Okay, so next is develop follow-up plan. When are you going to follow up your patient?
After a week.
After a week.
14 days. 14.
Okay. Well, the use of chronic PPI therapy, okay, whenever we have, patient taking a lot of PPI chronically, then there will be like increased case of hip fracture, okay, in the case of postmenopausal women, and then possible reduction in bone mineral density, okay. So in this case, definitely you want to follow up. In the case of development of osteoporosis, there will be like, giving all those supplementation like vitamin D, okay, calcium. That could be, that could be one of the things that you want to do. So in this case, PPI therapy should begin to improve symptoms within 7 days, right? So you need to continue from 8 to 12 weeks, okay? Probably around 2 to 3 months, all right? So you have to reschedule, okay, or schedule an appointment at 2 to 3 months. So 8 to 12 weeks, that could be the best way of monitoring. So the answer is actually 8 to 12 weeks appointment with gastroenterologist. Okay. Okay, next. Okay, so that's all actually for our tutorial. Do you have any question?
So
Mm-hmm.
let's say for PPI, right? It can be used for long-term therapy, but then for those with antiplatelet, is there any specific time frame when we can just omit the PPI from the regime, or just continue whenever patient has the dyspepsia symptoms?
You mean the patient is actually prescribed with PPI and clopidogrel, for example? Am I right?
Yes.
Yeah. And of course, we know that these two medications are interacting because of all these liver enzyme inhibition and whatnot.
No. I mean, let's say patient was prescribed with it's either I mean anything for the ACS treatment. Usually they will prescribe a PPI as well as part of the therapy. But then we know that PPI can be taken for long term period. So can we just can we suggest or is there any specific time frame, maybe after 3 months of therapy ke, or 6 months ke, that we can propose the prescriber to just omit the PPI?
Well, actually, we can in order to make sure that the patient receive all the benefits. Okay, so you can always play around. Okay, but again, you have to monitor patient clinical presentation, whether it gets better or it gets worsen. All right. So in this case, yeah, definitely you have to to recommend or maybe stop the medication whenever you feel that the patient can can start to heal, okay, all those clinical presentation. But again, it must be based on gastroenterologist further assessment or clinical consideration. Okay, there is no right or wrong, but of course, in clinical setting, we are looking at patient itself, even though theoretically it should be avoided, but sometimes they just proceed and then look for any arising problem. Okay, if it persists. Okay, so in this case, well, there is no clear answer for your question, but we try. Okay, we try to give the best suggestion for the patient whenever we think that it could be what we call it the best solution for patient current clinical status. So in this case, well, there is no clear answer for that. Okay.
Okay.
All right. Okay. Anyone? Okay. If no answer, if no questions, okay, then I leave you with this slide. Okay. I will upload. Okay. All the the additional materials that I put on this tutorial, and I hope to see you again for other activities in 701. Okay, let me know if you have any further question. We can always discuss through forum, through UFuture, and that's it. All right, thank you very much. Assalamualaikum.
Thank you, sir.
Thank you, sir.
Thank you, sir.